afternoon and good evening to everyone all over the globe, and welcome to the 6th Sigvaris Group Global Medical Online Hub. My name is Stephanie Vuillermo, and I am part of the corporate medical marketing team at the Sigvaris Group headquarters in Switzerland. The goal of the Medical Online Hub, or MOH as we call it, is really to bring together medical experts from throughout the entire world and to discuss state-of-the-art topics in the fields of veno-lymphatic disorders. In today's MOH, global female experts will share their insights about the manifold benefits of compression therapy throughout pregnancy. They will touch upon multiple topics such as nausea, vomiting, chronic venous insufficiency, venous thromboembolic events, and many more. And because at Sigvaris Group, we really strive to promote the exchange of scientific knowledge on a global scale, we are also giving you, the audience, the possibility to actively participate in our discussion via the chat function. So please feel free to send over any questions or comments that you might have at any time so that we can then discuss it with the speakers and the panelists. On a personal note, I am really looking forward to some dynamic and lively discussions today, and I wish you all a wonderful and fun MOH. Having said this, I now have the pleasure to introduce our principal moderator, Dr. Annelise Rodriguez, who has kindly joined us today. Dr. Annelise Rodriguez is a renowned vascular surgeon, phlebologist, anesthetic doctor from Brazil. And she is the owner of the Dr. Annelise Rodriguez Clinic in Cuiabá, dedicated to the global care of varicose vein patients. She is member of the Brazilian Society of Angiology and Vascular Surgery and a former fellow in endovascular surgery and complex vascular surgery at the University of Barcelona in Spain. Annelise is also extremely active on an international level. She participates as a speaker at various events such as the UIP, the VWIN in Dubai, the Canadian Society, among others. And last but not least, she is a mother of 2 young children. So for me, Annelise, you really embody the perfect superhero working mom. It's a real pleasure having you here today. Thank you so much for your time and interest. And now I hand over to you.
Okay. Thank you. Hello, everybody from everywhere who's joining us today. And thanks, Stephanie, for such kind words. I wish I could be half of this kind of superhero, you say. Well, thanks also to Sigvaris to take the opportunity for this. And let's get to work, right? So I'm very proud to introduce our first speaker, Dr. Erika Mendoza from Germany. She runs her office in phlebology in Windsor in Germany and also works in public health over there with phlebology and also with Doppler treatments. She's the president of the German Shiva Society and also a board member and general secretary for the German Society of Phlebology. She's referring and faculty to many international and national meetings, and not to mention all her activities as a teacher and numerous published papers and books. But what I think it's like the most highlight is how engaged she is in postgrad and also with learning and teaching in an international level. So I hand it over to you. Let's hear everything she has to talk because we are really excited about it.
Thank you so much, Annelise. And thank you, Stephanie, also for the introduction. I know you are also a super mama with children. I had the opportunity to see personally, and this was very great. Yes, we are happy. Thank you, Sigvaris, for this opportunity. And I will go right ahead to show my slides. And this is the topic, venous and non-venous symptoms in pregnancy. And I now have the problem that I don't see my slide because I see here the, I think, yeah, okay, I managed that. Okay, venous and non-venous symptoms in pregnancy, how might compression help? And I would like to add, and this is a little bit of PR, that I will be the president of the German Society meeting in Hanover in September this year and next year of the EVF, the European Venous Forum. And Corona have given us one good thing, at least, is that we can do lots of things online. And so lots of you possibly might share us in our sessions. Disclosures, the study I will present here was paid, the material and the statistic advice was paid by Sigvaris, and it's supporting this lecture, of course, and I have given other presentations, but they don't influence my presentation. Now, the classical indications for compression in pregnancy, like always in other situations, is of course if you have edema, to treat it or to prevent it. Of course, if you have thrombosis or varicose veins, and especially in the pregnancy, in the first third and in the third third, you can have edema. So I always recommend to have the stockings. And pregnancy, but also delivery, is the phase of the life where the thrombosis is the most important risk in women. So I think also for that, pregnancy is a moment where at least calf compression stockings should be worn. And there is a study with very little patients, also supported by Sigvaris in the 90s, where there was a possible prevention of varicose vein progression, but this is not demonstrated yet. One very important study came from Allegra and Antignani and colleagues, where 100 women between week 6 and week 28 of gestation of pregnancy were asked to wear compression. They were offered if they want and if they would participate in a quality of life research throughout the pregnancy. And 30% of them didn't want any compression, 70% received a prescription, and 10% of these of the 100 of the global one wore them not regularly, and 60% wore them daily. And CVIC, this chronic venous disease quality of life questionnaire, was undertaken at admission to study, and then in the further contacts. The CVIC was repeated throughout the pregnancy, and for women with compression, the value was continually decreasing. So those with compression daily decreased in 13 points from start of 48. Those with compression around twice a week decreased in 10 points from starting from 43. And very interesting, those without compression, and they would not be given compression throughout the pregnancy because they also didn't develop edema or complaints or thrombosis, of course. They started at a lower level with the 36, and they increased the quality of life points, which is that it impaired in 4 points. I will show this in the graph. The lower the value, the better the quality of life in this case. And so the green ones was those that chose not to wear compression, but they really had a low quality of life impairment at the moment they were asked. The other ones had a higher quality of life impairment, and this correlated also with the willingness of wearing compression throughout the time. So those with the maximal symptoms at the beginning had a good decrease of those. And I think this graph is very, very plastically showing how this helps. The authors conclude that women with symptoms of chronic venous insufficiency reduce these symptoms during pregnancy if they wear compression. And I, as also a mother of a child, and I had unfortunately lost one, I know from 2 pregnancies that you have symptoms of chronic venous insufficiency at the beginning and at the end of the pregnancy. I mean, you have heavy legs, and you have this tiredness and this stiffness in the legs. And so I really think every woman should be given to the beginning of the pregnancy compression. So now we have seen this classical general indication for compression, and I think there are 2 other points that are really interesting. There is an old study considering the reduction of heart rate after getting up. You know, sometimes when you get up in the morning, the blood is going out of the brain and you see red points or black points. This is very often happening in the pregnancy, especially in the third part of the pregnancy, in the third trimester. And this was published by Austria at colleagues. And they had 18 women in the week 32 to 38 of pregnancy, and they put them on the tilt table and measured the heart rate of mother and fetus in supine position and then rising to 60%, nearly upright. And normally, even in non-pregnant persons, the heart rate always increases until the bulb corrects the heart frequency, the blood pressure goes up, and then it regulates down the pressure, the heart frequency. And with compression, this increase was significantly reduced. I found the old work and I made a screenshot of this. This was mother heart rate with compression without, and fetal heart rate with and without compression. And you see in supine, in both cases, it is really most the same. And if you put the mother up without compression, it goes up from 89 to 100. And if you put it up from 89 with compression, from 89 to 94. And this difference was highly significant between these both. And the same happened to the fetus. Also, the fetus had less stress when you got up as mama. So this is really interesting. I mean, it's a completely logical thing, but sometimes you have to run a study to show that logical things happen for real. So if you wear compression, the blood will not drain to the calf veins in the first moment, but if you have a compression stocking on the calf, the blood can stay up in the body, in the brain, and in the carotid bulb, and so this fainting does not happen, or is much less. I think this is really also a very interesting observation, which I always recommend also to women, lots of women with low blood pressure. I recommend them to put compression stockings to avoid this in normal life also. And so now we are coming to the main topic, which was my study I did. This was the prevention of nausea and vomiting in pregnancy. So 50 to 80% of pregnant women suffer from nausea and vomiting in pregnancy. And this has, of course, a negative repercussion on the quality of life. And up to now, we have no proper therapy because we really don't know the reason neither. And some medicaments claim an effect. And a new drug was just admitted, doxylamine, in America and now also in Europe. But women in pregnancy prefer really not to take drugs. So possible reasons for this nausea is that the human chorionic gonadotropin could cause it, and it is highest in the first trimester. And the higher the HCG concentration, this correlates with more nausea and vomiting. This was demonstrated already. And both the higher HCG and the nausea and vomiting correlates with less dead-born children and the higher birth rate. So it looks like the human chorionic gonadotropin improves the pregnancy with the side effect that it provokes the nausea. So you could tell the woman, if you have nausea and vomiting, the best for the children. But I mean, in our normal life, it's a little bit bothering. The gestagenes, the hormones in pregnancy, the HCG also lessen the efficacy of contraction of smooth muscles. These are those we have in the esophagus, in the stomach, and the intestines, in the bowels. And this could also be a reason for nausea and vomiting, the direct effect on the smooth muscles. And this also could stimulate, this nausea could stimulate the lady to be more conscious of herself. I mean, if you remember how women lived for millions of years, working in the fields and so on, if they felt not so strong, perhaps they reduced their activity. This was really proposed by a colleague studying the causes of nausea and vomiting. And this could protect the woman and so the newborn. During the pregnancy of my daughter, I had nearly no nausea and vomiting during my working time in my office. And at the weekend, the symptoms were worse. I mean, I live on the countryside and there are smells. And I was wondering, how could that be when I come home? Why is this? And one day I came across the question, perhaps it is because what I do different. When I come to the office, I put compression stockings on to show the patient how they work, how they sit, and that they are different and wonderful models and so on. And so I tried compression stockings on the weekends also, and the nausea was gone. In my case, this was really like a on-off effect. This was really outstanding. And so I started asking patients in their first pregnancy week. Sometimes you have patients, we are pregnant, and they come for thrombosis or for edema or for whatever. And I asked them just if they had nausea And then I phoned them 2 or 3 weeks later asking. And they also had a relief in nausea and vomiting. So then I started with ethics and so on, and found Sigvaris as a partner to do this study. And we were brainstorming about the reasons, the possible ones. And another reason could be that the blood volume in pregnancy is increased in 1 liter, and the reduced hemoglobin makes a little bit more less oxygen to the brain. And like the esophagus, also the vein walls suffers relaxations from the smooth muscles. So the calf volume could be with 1 liter, and with the relaxation of the smooth muscles in the muscle veins could be filled with blood. The blood could be pooled in the calf in this time, and so the compression stocking could reduce this filling. This was a possible explanation. So now we go to previous studies. This one is a study by Lacroix, and they measured the extent of nausea and vomiting throughout the weeks of gestation and pregnancy. You see, you start week 7, which is when you take it really, this is the 3rd week after the embryo is, the cell was fecundated. And you see that it increases until week 9, 10, 11. And then it decreases again. And this is meant to be so because in this time, the HCG is the highest to allow the fetus to go to bed in the uterus and not be exposed. And this is the curve. So if you plan a study, you have to, people have to be aware of their pregnancy, and we have to have the highest value of nausea and vomiting to have good results. So we tried to pick patients in this moment, and we would examine these 4 weeks. We would try to make 2 weeks with compression and 2 without. And we had to make a crossover design with randomized order, because of course, if you put compression in these 2 weeks and no compression here, you will always have better effects without compression. So we randomized it. I will show you. And the target was to make the study in these 8 to 16 weeks. So this design parallel with placebo and controls I have explained in crossover design. So the same woman wears 2 weeks compression and 2 weeks not. And the order, compression first or compression second, this order was randomized. And so starting at week more or less 10 was the result. And we called it compression first and compression second, the 2 groups. We used standardized questionnaires. They come from Canada. They are really very good in this topic, which is the nausea, vomiting, and pregnancy questionnaire. So you have one for the last week and one for daily. And then I added questions for dizziness, because I myself noticed that the compression stocking was reducing the dizziness. Then also we used the CVIC, like Allegra, the leg-related quality of life, and we asked questions for tiredness. Pregnant women had to be over 18 years with mild or medium nausea and vomiting, because the strong ones, they have to go to the hospital. And we wanted to have 30 women per group. And it took us to randomize 74 women, because some of them lost their baby, some of them didn't return. And we had in the final evaluation 48 women. Exclusion was severe nausea and vomiting. And if they had a post-traumatic syndrome or nausea or edema or already varicose veins, because they were recommended to have their stockings anyway, if we didn't find an arterial pulse, which never happened, and if the measurements of the calf needed custom-made stockings, because the time would run away and we couldn't do the study then. If they already were wearing compression, of course, they couldn't participate, and if they couldn't speak German, neither. They were given 2 pairs of Sigvaris cotton compression class 2 German, which is compression class 3 all over the rest of the world. But I'm completely convinced that it doesn't make the point. And they received 2 pairs of compression stockings for the weeks with compression. And they had to give it back. If they had compression first, they had to bring the compression with them to be sure they would not have any in the second part. So the first day we made all the questionnaires, and then we did the randomization, and we had in the global 4 weeks, and had 2 weeks compression first and 2 weeks compression second, and or 2 weeks without, as I have explained. We had no difference in age, body mass index, and so on between the two groups. And let's go into the group 1, the compression first. They had first 2 weeks with compression, followed by 2 weeks without. We randomized 33, and we had lost to follow up 4. 3 of them lost their children, and 1 did not complement the questionnaires correctly, and we noticed this at the end, so we had to exclude her. In the group 2, they started without compression and then had the 2 weeks with compression. We had to randomize 41. This means always when a patient didn't show up, we put the ball again back to the basket to have at the end 30 balls taken out. And it was very interesting. In this group, all came back. All those receiving compression came back. But in this group, which didn't receive the compression for the first time, 9 did not return. It's interesting. They felt like, we don't receive anything, so we don't come back. This was very interesting in my eyes. And in both groups, we at the end had 29 patients to evaluate. As I told you, if any of these were present, we excluded the ladies from the study after we had made the exploration. And we organized all this in the telephone contact. At the day 0, we made all the explanation. With duplex ultrasound, we looked if they have or not varicose veins, and they had to complete all the questionnaires. And day 14, they had to come, and we did the questionnaires again, and we did the measurement of the leg perimeters. And at day 28, the same procedure. And they had to complement a questionnaire of 30 questions validated in studies for vomiting, 20 questions of the CVIC, and 4 additional questions which I developed for dizziness and tiredness. And then they had at their home a daily questionnaire. They had to send us every day, 10 days, every week. They had to send it by post. This is the PUKE, which is the daily questionnaire. How often did you throw out today? How much hours did you feel bad? And how much hours did you wear the compression, just to check the compliance? On one side, the results were that 100% had a high compliance. 100% of the patients were them between 5 and 8 hours or longer a day. 80% answered with yes when we asked if they would recommend the procedure to their friends. And there was significantly less nausea and vomiting, and less pain, and less psychological and physical complaints during the compression phase. So if you need, this blue line is the line we know from this bars. This is the extrapolation line of the nausea and vomiting quality of life questionnaire by Lacroix, and the dotted line is the mean for this time for the week 10 to 16. If you look at the results of the nausea, the orange line is the phase with compression, and the black one is the phase without compression. So if you see the black line, it is more or less parallel to the blue line of the natural evolution of nausea and vomiting in these weeks. And if you see the orange line, you see that the phase with compression really reduces the amount of nausea and vomiting. And interestingly, this line didn't go up. So obviously the compression reduced the disposition. Perhaps, I don't know how, because normally if you extrapolate this line like this line had to go up to come to normal from the rest of the group, from the other studies. So it was very interesting that not only the lines went strongly down during compression, but the lower level was maintained through the second part of the study in those ladies not wearing compression in the second 2 weeks. We had 3 or 4 groups of questions: physical impairment, negative feelings, tiredness, and nausea and vomiting, and my 4 questions to dizziness. And we evaluated these in comparing comparison to the baseline. So we are expecting that the results from the day 0 would go improving anyway, because anyway, the longer the pregnancy goes, the symptoms are less. So this is 0, and this is the improvement of the symptoms. And if you see nausea and vomiting in total, the total one with compression reduced it much more than without compression. And these were the different groups. And this last one is the one with my questions. So percentage of change to baseline without compression was, let us say, the same as in the normal population. And the change, this is the additional change due to the compression we observed. If you look at the dizziness, this was really astonishing. Without compression, the dizziness didn't change nearly, and with compression, it changed very much. So another image to see the importance of these results. The blue one is without compression, the orange one is with compression. During the orange one, compression first, the decrease is strong. In the group with compression second, in the phase of no compression, the decrease is a little bit. And in the compression first group, in this evaluation, there is a little bit of increasement of the value and a strong down value in the second part of this group in lows varying compression second. If you look at the dizziness group, this is what I expected for the complete group. Compression first, decreased tiredness, and it get up in the second part, and it increased in those without compression first, and it went down in the phase with the compression. So in my eyes, it is very, very astonishing to see how this tiredness in the first part of the pregnancy can be positively influenced by compression. Here we have the evolution of the leg complaints. In the civic score, without compression, the complaints improve. With compression, the complaints are reduced. Comparing these results to a study made by Corin et al. To check the effect of doxylamine and pyridoxine. This is a pill against nausea and vomiting in pregnancy. The PUKE score, this daily score, was really the same reduction in our compression study. Of course, this was not a comparison study, but if you take the parameters and you compare, you can say that our PUKE was a little bit better evolving with compression than with pills. So we can conclude that wearing compression in early pregnancy improves significantly the leg-related quality of life, as shown by Allegra, the nausea and vomiting, and the dizziness and tiredness. And they could be a good non-pharmaceutical alternative to relieve the symptoms. And I would have loved it if any university in a capacity of making hormones in blood and so on would have taken the opportunity to go on investigating this, because I'm still very intrigued how the mechanism is. And this is the point where I hope I've not been too long talking, and I thank for the invitation to present these data, which are in my eyes very, very important to be translated for gynecologists, to be brought to them, because I think we could help these women in this situation. And I, of course, won't not stop without putting here the date of my Congress. I took choosing wisely, and I think choosing wisely for pregnant women is giving them compression stockings. Thank you so much for listening.
Thank you, Dr. Mendoza, for this lovely presentation. What I truly enjoy about you is just, your authenticity and how dedicated you are to your field of interest. And I just love the way you came up with doing this study in the first place. I just find that brilliant.
Thank you.
But before we get on and move on with the discussion, we do have a poll question for the audience. So if Khaled, you could please show the question on the screen, that would be lovely. Can everyone see? So the question is, in Dr. Mendoza's study, what was the percentage of pregnant women who would recommend wearing compression stockings during early pregnancy? 20, 40, 60, or 80%? You can answer now. We'll proceed with the discussion and we can discuss about these results later. So Annelise, I will now fly over to Brazil.
Open my mic. Thanks, Dr. Mendoza. It was really, really nice to watch and hear about all this different stuff. And I'm now presenting you our two panelists who are actually my dear friends, Lorena and Chantal. Dr. Lorena Grillo is from Costa Rica, and she's a specialist in peripheral vascular and general surgery. She's also a specialist coordinator at the Hospital Alajuela in Costa Rica, and she's the president of the FLEBO LATAM and the member of the board directors of the Association of Peripheral Vascular Surgeons of Costa Rica, and a LATAM project advisor for the Bowen Foundation in university, professor for more than 15 years and an international speaker. And alongside, we have Dr. Chantal Aguero, and she's graduated as a medical surgeon at the University of Asunción in Paraguay, and specialized in phlebology and lymphology at the University of John F. Kennedy in Buenos Aires. She's director of the Vanguardia Clinic and Clinical and Research Center for Venous and Rheumatological Diseases in Asunción, Paraguay. And she's the past president of the Paraguayan Society of Phlebology and Lymphology. So guys, I hand it over to you and to your comments or questions to Dr. Mendoza.
Well, first I want to thank Dr. Mendoza and all the group CVI for inviting us to participate in this very nice webinar. And I want to congratulate Dr. Mendoza for being, thinking always out of the box. And definitely, I think this is where great things begin, of being so meticulous, about finding some things that bring us our attention and deciding to take upon this great study. I was wondering, Dr. Mendoza, about were there any comorbidities that the patients showed in the study that you thought, maybe ruling out, or that you could define them to fill it, put them in a special group? And if prior nausea and vomiting in other previous pregnancies was an issue that you took in account?
Yes, really, I asked for general illnesses, and we were discussing with the ethics if, for example, hypertension in previous pregnancies could influence, or we should leave them out. But as hypertension occurs at the end of the pregnancy, and we are in the beginning, and the diabetes develops at the end of the pregnancy, we decided not to take it out. And all the women were young persons, and they were not especially ill. And normally those very with adipositas, they don't fit in custom-made stockings. And as these patients were excluded, I don't know if perhaps in this group we would have had some issues of medical kind. But generally they were healthy, and we asked for previous pregnancies, and we also asked for the level of nausea they had. And it was this more or less the same. They had more or less the same nausea in the second pregnancy, or in the studied pregnancy, than in the further earlier ones. But I didn't publish this point because I read a lot. As you know, I'm no gynecologist, and I had to read a lot of information to make the study properly. And they compared studies with retrospective evaluation of the nausea and day-to-day evaluation. And they demonstrated that the retrospective evaluation is really like doing nothing. You can't rely on it, because when the baby's born, everything was fine. Or when there are so many things influencing the feeling you had at the beginning of the pregnancy, that this information was not reliable. But looking at the data, it was more or less the same.
Thank you very much.
Thank you. Muchas gracias.
Thank you. We really feel that it's a very interesting topic, since me, myself, I am a mom too, and we always were thinking about compression in the last part of our pregnancy. Yes. We never think about the early stage and the early month. And I think it's really a very good study, and this publication can bring probably a better quality of life for women. And during those months, I think anything can help. And especially I was looking the two groups that you were choosing, and I think the first group probably were more the compression work, more efficiency during the 8 weeks. I don't know, it's very good to establish the best time to introduce a prescription for the pregnant woman. I don't know if, in your opinion, is gonna be around 8 weeks, or what do you think about it? And after this study.
This is a very important point. Thank you for the question, because I don't know how this is in other countries. In Germany, women used to go to the doctor when they have no menstruation. But I know that from other countries, they go when they are in week 12, or I know the pregnancy is further developed. And so I really try to recommend gynecologists, because ladies come and say, I want to get pregnant. And this, in my eyes, is the moment when I would recommend prescribing the stocking, because so you can wear the compression from the very beginning of the pregnancy. And on the other hand, in Germany, they receive a packet with information about the pregnancy, about how to do this, and about how to eat, and how to move, and which sports to do, and so on. And in this thing you receive in the very moment you go to the gynecologist, normally it's week 7 or 8 when you notice you are pregnant, and so on. In this packet there should be a receipt for compression stockings, in my eyes.
Yes, and especially for education, and it's important. We know our patients sometimes in young age. They grow up with us.
Yes.
they married, they become pregnant. So probably it's good to introduce this information. So
Yes.
then they know that when they become pregnant, they can come with us, and we can help them in
Yes.
the earliest stage.
Yes, of course. This is a very, again, interesting thing, but I recommend every young lady that comes to me to, I ask them, are you wanting to be pregnant? And if you do so, please use compression stockings. But I think that the most of the ladies in this age aren't visiting us. They are just really visiting the gynecologist. So their focus has to be the marketing for Sigvaris. The marketing focus has to be reaching out to the gynecologists. This is very important.
Yes, it is.
Okay, thank you, Dr. Mendoza, again. Thank you, Chantal.
Very, very welcome. Thank you all.
I pass back to Stephanie, so we can discuss the poll question maybe now.
Yes, thank you very much. Khaled, could you please show the answers to the poll question? Okay, so yes, everyone listened well. So yes, so from Dr. Mendoza's study, it was really 80% of the women who would recommend wearing compression during early pregnancy. I thought that was super impressive. And on a personal note, I can completely confirm. So it was quite interesting, because in my first 2 pregnancies, when I was not working yet for the company, I had no awareness. I really had no idea that this could help, and I had really, really, really bad morning sickness, like awful. Then I worked for the company, and started learning about this, about Dr. Mendoza's study. Then I had my 3rd child, and I was very, very thankful, because in my case, it truly helped, really, but for everything, not only the nausea, also the dizziness and general well-being. So thank you for that. I think a lot of women could benefit from it.
Thank you.
Annelies, do you have a comment for the poll answer? If not, we can pass on, I think, to...
No, I find it good that everybody was paying attention to it. And actually, I'm the one tending to act as a compression freak with every pregnant or even no pregnant women that come to me. My gynecologist friends are always asking about it. So I'm glad to hear we're on the right way. Next, I'm going to introduce our next speaker, Dr. Kathleen Hicks. She's an associate professor of surgery and director of the Johns Hopkins Center for Surgery Outcomes Research. She's also director of research and multidisciplinary diabetic foot and lung service and associate fellowship program director of the Division of Vascular Surgery and Endovascular Therapy at the Johns Hopkins Hospital. And she'll be talking to us about the chronic venous insufficiency in pregnancy. Hello, doctor. You ready for us?
Yes, thank you. Thank you to Sigvaris for the opportunity to present today. Just share that to make sure that's working. So I'm going to talk a little bit sort of about the hemodynamic changes that occur in pregnancy and how this results in chronic venous insufficiency. And these are my disclosures. This talk, of course, is sponsored by Sigvaris, and everything else is unrelated. So the cardiovascular system undergoes dynamic physiologic changes throughout the course of pregnancy in order to meet the demands of the mother and the developing fetus. These changes are essential to ensure the appropriate development of the fetus, but may reveal previously silent cardiac diseases and are associated with several venous diseases in the mother. The burden of disease from venous diseases in particular can be high during pregnancy. Venous thromboembolism, or VTE, including deep venous thrombosis and pulmonary embolism, are potentially lethal conditions that affect women nearly 5 times more often when they are pregnant compared to when they are not pregnant. And this risk actually further increases in the immediate postpartum period before returning back to normal. It's highly relevant because the mortality associated with VT is significant. VT is the #1 maternal death cause in developed countries. More importantly, really sort of the whole slew of things that happen during pregnancy that ultimately lead to VTE also contribute to a much less frequently discussed condition of chronic venous insufficiency, or CVI. It's very, very common during pregnancy, and affected women increased and experienced risk of varicose veins, leg pain, edema, itching, skin discoloration, night cramps, and a feeling of heaviness in their legs. Symptoms do start very early, as we sort of heard in our last talk, and continue throughout the course of pregnancy and sort of peak in the 3rd trimester when the hemodynamic changes related to pregnancy are most profound. So we know, the lower extremity venous system is composed of a series of superficial, deep, and perforator veins, all of which act together to return blood up from the legs to the heart. There's a number of valves in the veins that are meant to act as a one-way valve to ensure that the blood flows in the correct direction. But when you have sort of chronic insult from venous insufficiency, and we'll get through those specific insults as we move forward in this talk, some of these valves can become damaged over time, okay, sometimes temporary, but with sort of repeated insults with things like multiple pregnancy and other factors. And then these changes can become permanent, leading to chronic venous insufficiency that extends even after pregnancy. In a normal non-pregnant individual, the vascular system is sort of a closed loop, if you will, really. So the heart puts out a set amount of blood into the arterial system that flows out through the vessels, the capillaries, and then back into the venous system, back to the heart in a nice sort of cycle. The output approximately equates to the input, and so there's no swelling of the lower extremities because everything that the heart's putting out is being returned back up to the heart with these nice competent valves. But this isn't what occurs in people who are pregnant. So if this is some work that I've done, if we talk about hemodynamic specific changes in pregnancy, these are very dramatic and can alter the functions of that lower extremity venous system. There's really an intricate combination of neurologic and hormonal factors that result in ultimately an elevated cardiac output and heart rate, and a decreased systemic vascular resistance and blood pressure that contribute to this. These hemodynamic changes occur as early as 5 weeks gestation. There's a drop in mean arterial pressure that occurs during the 2nd trimester, which falls by about an average of 8 millimeters of mercury, or 9%. The systemic vascular resistance progressively decreases during the course of pregnancy, so throughout the entirety of the course of pregnancy, and reaches a nadir of approximately a 30% rate compared to below non-pregnancy values in that 3rd trimester. I will say after delivery, both the mean arterial pressure and the systemic vascular resistance do return to normal pre-pregnancy values, but certainly there is sort of a progressive insult over time. In terms of heart rate rises progressively throughout the course of gestation. The highest value occurs in the 3rd trimester as well, when it peaks at about 16 beats a minute on average per person, or about 24% compared to non-pregnant values. After delivery, your heart rate also returns to non-pregnancy values and remains relatively stable. where sort of I think the biggest insult is the cardiac output, which increases throughout pregnancy as a result of the increase in heart rate. It also peaks in the early third trimester, an estimated 1.5 liters per minute above non-pregnant values, or equivalent to about 31% increase. And then in the early postpartum period, so right after delivery, cardiac output drops down because there's a reduced maternal cardiovascular demand after delivery. However, there's then a subsequent modest re-increase in cardiac output in the later postpartum period by about 12% that contributes to sort of some late postpartum symptoms. So there's a number of physiologic changes that contribute to these hemodynamic fluxes that occur during pregnancy. These include increased vasomotor sympathetic activities, increased maternal baroreceptor sensitivity, and an attenuated response to alpha adrenergic stimulation. There are also hormonal changes that we know, including estrogen, progesterone, and relaxin, all of which are elevated during pregnancy and play a role in systemic vasodilation and increased venous capacitance. And then there may or may not be a role of nitrous oxide as well. This has been posited to play a role in mediating systemic vasodilation during pregnancy, although some of the data related to that is mixed. There are large effects on the renin-angiotensin-aldosterone system. This is hyperactivated during pregnancy from a very early stage as a result of the hormonal milieu in pregnant women. Estrogen specifically increases the level of angiotensinogen, which increases levels of angiotensin II. Those levels of angiotensin II then play a critical role in maintaining circulating blood volume in pregnant women, as well as maintaining blood pressure in order to maintain the uteroplacental blood flow. So if you look at what this means sort of in terms of the pragmatic terms of blood volume in pregnancy, the total blood volume increases by about 20%, all the way up to 100% in pre-pregnancy levels, with an average around 45%. There is an increase in erythropoiesis to increase the red blood cell mass up to about 40% compared to pre-pregnancy values, which is largely due to placental lactogen. However, there's a proportionally higher increase in plasma volume that results in this physiologic anemia from hemodilution that occurs during pregnancy. So we know that pregnant women are often very anemic. In reality, their absolute values are actually higher than normal, but they have a relatively more volume of plasma to red blood cell. All of these changes result in pregnant women being in a pseudo stress response state at all times, which leads to lower extremity edema and swelling. If we look at flow dynamics in pregnancies that are specifically related to the veins, there's a number of interesting changes. So anatomic and functional changes occur in the venous system during pregnancy. Both venous volume and the diameter of the lower extremity veins have been shown to be significantly greater in pregnant compared to non-pregnant women. And you can see here some data looking at venous volumes and then the diameters of common femoral vein, great saphenous vein, and the popliteal vein in pregnant and non-pregnant women. And all of these are significantly larger in people who are pregnant. The mechanisms that contribute to these changes are thought to include elevated levels of estrogen, reduced systemic vascular resistance, which I already talked to you about, as well as some venous stasis that's related to compression from the brevet uterus on the iliac veins and the vena cava. And that sort of looks like this. You can see here sort of as the uterus increases, there's some posterior pressure in the pelvis, and specifically at this point where the iliac artery crosses the iliac vein, you get some compression right here and here, and that can cause some sort of decreased venous outflow that causes and contributes to lower extremity swelling. So I showed you this figure before where sort of there's a closed loop in the cardiovascular system, sort of blood goes out, blood comes back in relatively normal, healthy people. In pregnant women, the cardiac output, very importantly, is very increased. And so there's more blood going out, if you think of it like that. And then we have less blood coming back, partly due to this sort of venous compression, partly due to decreased systemic vascular resistance, partly due to some leaky or incompetent venous valves. And so ultimately, we're getting sort of more blood flow than you can possibly handle coming out and then going back. And this leads to subsequent swelling and varicose veins in the lower extremities. And then all of these symptoms that I'd mentioned before. And then ultimately, well, we think of chronic venous insufficiency being sort of a pregnancy-related phenomenon. If you sort of have multiple hits as this really does cause a lot of stress to those venous valves and ultimately can lead to incompetence that persists beyond pregnancy and into sort of your older years and leading to sort of chronic venous insufficiency unrelated to pregnancy. It's important to note also that there is Virchow's triad and pregnancies. This consists of venous stasis, endothelial injury, and hypercoagulability, all of which predispose to thrombosis during pregnancy. So venous stasis is due to that pressure influence of the uterus on the IVC and iliac veins, and also the decrease in blood pressure and systemic vascular resistance that I'd mentioned. Endothelial injury results from stress placed on the blood vessels due to increased plasma volume, which is mediated by that activation of the RAAS system that I mentioned. And then finally, Virchow's triad is completed in pregnancy by the establishment of a hypercoagulable state. And this, again, back to some work that I've done, you can see sort of here, this is a summary of what happens to the coagulation changes in pregnancy, but really the coagulation factors and adhesive protein von Willebrand factors all rise significantly in addition to heightened fibrinogen levels. There's also critical changes in the anticoagulation system manifested by increased thrombomodulin, decreased protein S, and increased resistance to activated protein C. Finally, fibrinolysis is impaired because of increased plasminogen activated inhibitor, decreased tissue plasminogen activator, and acquired antithrombin deficiency. So, I mean, why does the body do this? It seems sort of like a really, really profound response to pregnancy. And the reality is what we think it is that it's really that these changes are created in response to protecting the mother from excessive bleeding sort of in the delivery period. But unfortunately, it also puts women in a prothrombotic state throughout the peripartum period. As a result, women are at increased risk of VTE and other venous diseases compared to non-pregnant women. So if we look at what the epidemiology of chronic venous insufficiency looks like, sort of in general, you can see here that a number of epidemiologic studies have looked and shown that the CVI affects approximately 10 to 35. In this study, you can see there's some functional disease, which is sort of just some cosmetic issues, and actually quite a large number of patients, only about 22% were considered normal. Everybody else had complaints of spider veins, most commonly followed by varicose veins and trophic changes. But certainly there's some superficial functional disease presence in about 15% of people, and then deep functional disease in 5% of people. And these are people that are not pregnant. So these numbers are expected to be quite a bit higher in pregnant women. Pregnancy, along with obesity, a history of DVT, smoking, and family history are well-described risk factors for venous reflux and subsequent CVI. In the pregnant population, primary chronic venous insufficiency is evident in up to 80% of women, at least in some form, with the majority of affected individuals reporting symptoms of leg edema and pain, sometimes night cramps, numbness, and itching. Onset typically occurs in the first trimester because those hemodynamic changes do occur early, but increases over time to sort of reach a peak in that third trimester. And then the risk of CVI, as I sort of alluded to before, is classically worse after each pregnancy because it's just these multiple hits again and again, and these can lead to sort of long-term sequelae. So to take a quick pivot here, when we talk about venous disease of the lower extremities, we often use the SEEP classification or the clinical manifestations as etiology, anatomic distribution, and pathophysiology. And really varicose veins, which represents a SEEP class 2 disease, affects up to about 40% of women with primary CVI. So a lot of women having sort of telangiectasias and reticular veins or some spider veins after pregnancy, but still nearly almost half of people affected by some sort of varicose veins, at least in the pregnant period. There are potential complications related to this, including thrombosis, inflammation, or thrombophlebitis, and bleeding. If you look at VTE, so venous thromboembolic events in pregnancy, this risk increases with time, with pregnancy, so very consistent with what we've seen with sort of the overall hemodynamic changes, although the incidence is actually quite low. It's about 0.25% of women who have natural pregnancies and about double that in people who undergo in vitro fertilization due to some changes in the hormone milieu. But when you sort of look at the expression of where VTE occurs in pregnancy, the majority of these again are happening in that third trimester. So the incidence is quite low, but it is worth showing this slide again, which I showed you sort of at the beginning. Despite a relatively low incidence, the morbidity and mortality related to VTE is really, really substantial. And that's why this matters so much in the pregnant population, which is otherwise usually relatively healthy. So how do we treat this? Well, there's sort of two arms. There's a non-pharmacologic and the pharmacological arms. As with treatment for chronic venous insufficiency in non-pregnant individuals, really non-pharmacologic approaches are used in an effort to minimize more invasive measures. These include a few things like staying active, elevating your legs when seated, and then wearing compression stockings, which we started in the first talk, and I'm going to touch on again a little bit here. And this is really sort of the cornerstone of preventing CVI throughout pregnancy and then also those long-term sequelae. So in terms of compression stockings, these serve as both prevention and treatment. So pregnant women, and I totally agree with what was said earlier on, these should be started to be worn, right as soon as you even think about getting pregnant, because it can prevent a lot of problems that lead you to avoid those sequelae long term. So, these are used in the treatment of things, blood clots or VTE, and in the treatment of varicose veins and swelling and spider veins and tired and achy legs. But really, if you can wear them before that, a lot of these symptoms can be avoided or at least minimized. The compression therapy acts to improve drainage of superficial venous blood, therefore reducing the risk of overdistension of the venous system with the blood return, and then decreasing symptoms of chronic venous insufficiency, while also potentially preventing thrombosis in higher risk patients. There's good data to suggest that compression therapy is a successful strategy to reduce venous stasis and thus decrease risk of CVI, both in the peri and postnatal periods. There's a lot of different grades, obviously, of compression therapies. And I think, a lot of pregnant women end up using sort of this slightly lower grade. Ideally, if we can get them into the 20 to 30 millimeters of mercury, that would be ideal. But even sort of anything is better than nothing, I think. And certainly these come in the below the knee and then the thigh compression. I think one of the biggest issues with compression therapy is really patient compliance. And so these thigh compression stockings can be very difficult to wear. So in many people, sort of just starting with the below knee compression provides substantial release with sort of less issues with adherence. Always some points about how to use compression stockings effectively that I use with my patients. Specialists can actually measure you for a good fit, because a lot of the times the patients will come back and be like, I just could not get them on. And sometimes they're just not being sized properly, at least in the United States, and be curious to sort of hear what it's like otherwise. But stockings are almost always covered by insurance, especially in people who are pregnant. Really, they're meant to be put on first thing in the morning, worn all day while walking around, and then taken off back again at night. Patients are meant to feel the pressure most around their ankles. Usually these have graduated compression with the strongest compression in the toes, and then sort of a slow decrease moving forward, which sort of helps move that blood from the foot all the way back up through the calves and up into the pelvis and the IVC. Stockings are supposed to be washed and then should be replaced every 3 to 6 months for support, probably more if you're wearing them literally every day. Just very briefly, some pharmacologic treatments of CVI, really limited data on this, and some questionable effects on fetal growth. So really for advanced disease only, and I would not recommend it. In terms of superficial thrombophlebitis, which is sort of a sequelae of chronic venous insufficiency and pregnancy, the mainstay of therapy there is compression and NSAIDs, or non-steroidal anti-inflammatory drugs. So in pregnant women, this is typically acetaminophen, although you can use naproxen in people who are in the first and second trimesters. But compression here, again, being sort of the key. If you have severe superficial thrombophlebitis, there may be a role for systemic anticoagulation, sort of in the pregnant population, either in the terms of unfractionated heparin or low molecular weight heparin. And then danoparade works quite nicely, but is not available in the United States. This is sort of the treatment algorithm for superficial thrombophlebitis. So if the one big thing that we worry about in pregnant people is them developing DVT, so that's a venous thromboembolic event, because of the risk to mortality. So those patients should be treated with therapeutic anticoagulation. People who have isolated confirmed superficial venous thrombophlebitis, really their ultimate treatment depends on sort of the characteristics of the clot in the superficial femoral vein, distance from the saphenofemoral junction, how long that clot is, and then they either are treated with anticoagulation or NSAIDs. But the reality is that all of them are treated with compression stockings. That's sort of a common theme. No real role in pharmacoprophylaxis for VTE prevention. Really, the main role in VTE prevention in pregnant women is compression stockings. And so that's what we can do best to counsel our patients. There's some exceptions here, people who had previously unprovoked DVTs or some deficiencies in factor V Leiden, prothrombin G mutations, or antiphospholipid syndromes should be using compression in combination with anticoagulant therapy. You can see here, this is a really nice summary that was published in JACS in 2020, looks at sort of VTE treatment in the pregnant population. And you can see here, anticoagulation is obviously mainstay. There's some others, advanced therapeutics, including systemic lytics, catheter-directed thrombectomy, embolectomy, and open thrombectomy. But what I think is really missing here is the compression stockings, which we are used in both prophylaxis and treatments of all VTE in pregnant people. And then finally, the use of IVC filters can be used in pregnant women with either high risk VTE or who have failed anticoagulation and have an active VTE. These in pregnant people are usually placed in the suprarenal position. This is showing an infrarenal position, but they're moved up a little bit just to prevent some compression by that gravid uterus. But again, in those patients, the other thing that they should be getting is compression therapy. So you're sort of seeing compression therapy again and again and again in the paradigm here of treatment. So in summary, the maternal vascular system undergoes dynamic and extensive changes during pregnancy. The resulting stress does place that mother at increased risk of developing lower extremity venous disease. The relative risk of VT occurrence during pregnancy is high, but the absolute risk is minimal, although the mortality rate associated with that is significant. And what is not talked about as often, but is very important, is that the relative risk of chronic venous insufficiency is much higher than that of VT and affects most women who are pregnant and many women in the longer term. And there are a number of strategies that exist to manage lower extremity venous disease associated with pregnancy, but all of these involve compression therapy, and it really plays a key role in the prevention and treatment. So with that, I'll say thank you, and I'm happy to take questions.
Thank you very much, Dr. Hicks, for the enthusiastic presentation. What I really think, I really think that your presentation nicely showed the complexity and wide range of physiological changes that can occur throughout pregnancy. And before we move on to the poll question and discussion, I do have a small question just because it popped into my head. You were mentioning, you know, that the iliac veins, that there's a mechanical pressure obviously from the growing uterus. Do you think it's a little far-fetched to say that pregnancy could be a cause, or at least a risk factor, for pelvic congestion syndrome? You know, pelvic pain.
Yeah, it's a good question. I mean, I think, as you mentioned, it's very complicated. So there's a lot of changes occurring during pregnancy. The compression of the sort of the iliac veins really does happen in the later stages of pregnancy, because it's when there's a really gravid uterus. So it's not like it's happening for 9 months per se. I think, you know, in the moment, you do occasionally see people coming in. Obviously, left-sided DVTs are more common than right-sided as a result of that. I think in terms of sort of pelvic insufficiency, whether that can create chronic long-term effects, the answer is I don't actually know. But I think sort of based on everything else that we know with endothelial injury and sort of some venous stasis changes and whatnot, that it probably plays at least some role. I don't know how much.
Okay, thank you very much for the answer. Khaled, could you please show us the question? So the question is to the audience: do you prescribe compression therapy to pregnant women? And if so, which compression class do you prescribe? 4 possible answers: yes, 18 to 23 millimeters of mercury, yes, 20 to 30, yes, 30 plus, and no, I do not. And we'll look at the answers later, and I think now we can move on to the discussion with Annelies.
So, Lorena, do you have any comments or questions to Dr. Kathleen? Please go on.
Well, I wanted to congratulate Dr. Hicks by such a comprehensive talk, you know, with going all through the hemodynamics. And it's so important, you know, to be able to being able to listen to this as you talked about it. And also the importance that compression gives us a very useful tool in the signs and symptoms of chronic venous insufficiency, and also in the prevention of venous thromboembolism. And in a population so specific and special as pregnant women, in which we don't want to furthermore have any preventable risks. And as we have been talking all throughout these couple of years, that is one of the first preventable causes of death, more so in pregnant women and also the fetus eventually. And also the importance in which that pregnant women are not a easy population to study regarding drugs or other things. So definitely being able to compress the extremity, and even before the patients become pregnant, being able to teach them the importance and how does it work. It's a patient awareness a field of work that I think we have been started, and that is so useful. And I think that you explained it so well, but I just wanted to emphasize the importance of bringing this to patient awareness.
Thank you for that.
Yes, I feel the same way.
Comments?
Yes, I feel the same way, and I also think that when we start talking with our patients about compression, I know during the pregnancy, trying to activate our muscles the muscle pump is more difficult, sometimes for medical reasons and other for the mood we feel during those months. And I think the compression really is a passive way to do it and help a lot. And now we are learning that during the early pregnancy month, and also we knew already about the late month, and it's really very good to see the presentation from Dr. Hicks and see all the physiological way that how it works, and it's really a lot of information. I think that after pregnancy, sometimes we don't know exactly when to start a treatment. I don't know if you have an opinion about it, because of course compression helps during pregnancy. We cannot work actively with a treatment, and sometimes breastfeeding comes after it. And I don't know if you have a time or suggest when to start an active treatment with the patient.
Sort of active treatment, I guess, in terms of continued compression, or is that what we're talking about? Yeah.
I mean a treatment, sclerotherapy or surgery or whatever is needed for the patient.
Oh, for for chronic venous insufficiency. Yes, that's a great question. As you mentioned it, or I think, Lorena maybe mentioned, it's really difficult to study pregnant women. So I don't know that we have evidence-based data on that. But I would say for people who have been pregnant and have chronic venous insufficiency that I see in the clinic, if they are in that sort of almost the first year really of the postpartum phase, and certainly if they're still breastfeeding, because there's a lot of hormonal changes related to that, I would not advise anything more aggressive than just compression therapy. And honestly, I think, it's a little bit of a balance, because a lot of some of these chronic venous insufficiency changes will return sort of a little bit back to baseline, not all the way to baseline, but they'll improve from what the patients are suffering. So if you treat too early, you're perhaps leading to some overtreatment. So I think sort of maintaining a conservative management approach and really following those patients with their use of compression. And if they're sort of well past that sort of peri or postpartum period and they're still significantly suffering, then that's when you can consider it, but certainly not early on.
Mm-hmm. Thank you.
Thank you, Kathleen. I have some questions but I'm holding it for when it's my turn. So I'll go back to you, Stephanie, for the full question and answers, please. You're muted, Stephanie. You're muted.
Thank you. Sorry, Khaled, do we have the results of the poll question? Okay, so most of you, 60% of you replied that yes, you do prescribe compression to pregnant women, and if so, 20 to 30 millimeters of mercury. And well, that's interesting because it really is in line with the literature. Most of the studies that I have found really mention 20 to 30. I did find one using 15 to 20 millimeters mercury and showing that it was enough to reduce leg pain and increase the quality of life. I wonder if the 20 to 30 also is an insurance issue, and reimbursement issue. I know that here, for example, 20 to 30 will be reimbursed, not a lower compression class. And Dr. Hicks, to your, I think you had a question or comment earlier regarding insurance. I can't generalize to the whole world, but what I've noticed, I think, is that it's getting sometimes increasingly difficult to get compression reimbursed during pregnancy, which I truly don't understand. So I've heard from some customers who have, so gynecologists who have prescribed compression stockings to their pregnant patients, and the health insurance did not want to reimburse for various reasons. So that remains a mystery to me. I don't know if anyone else can confirm if this is a general trend or no.
Yeah, I haven't really had problems, but I will say, a lot of these compression stock, even anything is better than nothing. So even if it takes a little bit to get some insurance authorization, I usually tell patients to just buy something over the counter to begin with, and then we can sort of work through it.
Right. Annalise, do you have a comment regarding compression class? Or
No. Kathleen, I was wondering, actually, I was even talking about it with Stephanie previously, that when you consider all those hemodynamical changes and the overload in a pregnant woman, do you believe there's a difference when it comes with the stocking length that you prescribe to your patients, like knee highs or full length at any given moments? Because normally I'd say to them, you can wear like knee highs in the beginning, but once it starts to show off like the growth, I tend to put them on full length. But I don't know if it's like important. What do you think about it? What do you have to say about this?
Yeah, I think as you move into the third trimester, the ideal thing would be the thigh highs, because you do have some venous stasis with the gravid uterus on the iliac veins. So I think that really sort of can help push that venous return forward. But I sort of alluded to this. I think a lot of the issues, and I see this in my patients, is adherence. So if I prescribe thigh highs, they just don't wear them. So I'd rather prescribe knee highs and have them wear it the whole time, and then thigh highs and have them not put them on.
And do you have time for the questions from the audience?
I've
Sure.
had one small question regarding the assessment of the risk of venous thromboembolism in the pregnant in the scorings of ACOG and ARCOG. What is the status in the other countries on actually doing performing the scores on the pregnant patients, you know, before they have the complications, so that maybe we could also have a scoring that is already standardized that could help us maybe overcome this insurance problem, or maybe see the importance in which patients we cannot fail them.
Yeah, so you're sort of speaking to identifying high-risk patients that are going to be more at risk of having sequelae than less, perhaps. Is that I'm interpreting your question correctly? Yes. Okay. I think scoring systems are really important. They can help us sort of identify people who are at high risk of VTE. My one restraint on that would be that if you introduce scoring systems to try to identify who should get compression to prevent VTE, then you give the insurance companies an out of who does not need to get compression. And I really think, you know, we've heard with Dr. Mendoza's talk earlier and the stuff that I've presented, that it's valuable in everybody. So I think there's a use of scoring systems clinically for physicians, for us to counsel patients on what their risks are. And certainly when you're identifying other pharmacologic adjuncts besides compression, to see if those are important. But I would not want to see that probably universally applied to the use of compression therapy, because I think it should be universal.
Thank you very much.
So,
I have,
yes,
I
just wanted to give you the same question that I gave her about the compression lengths.
Yes.
So what's your daily?
Like the colleague had said, Kathy has said, the most important thing is that the patient will wear it. You have ladies that always wear short things and like dresses, and then of course you will give them long stockings. But my experience with most of the patients is when you change weight, and then the long stockings tend to go down to the knee and make problems in the knee fold. And my experience really is that the short stockings, the knee-long stockings, are much more worn than the long ones. And you have to have a look at this. The patients have to come with a stocking on the leg to see how it really works. And I would only prescribe long ones if they really have varicose veins from the great saphenous vein. Then I really recommend to take the long ones. In all the other cases, I allow them to choose.
Apart from my questions is more like, I always say them wear something instead of giving them something that they will not wear. But my question is more in the hemodynamical way. Do you believe it's actually would make a difference if they would wear it? It would be better to wear like longer ones, or no, like by the third trimester maybe.
There is a wonderful study from Parch demonstrating that only 15% of the effectiveness of the compression stocking in the long stockings, in the thigh stockings, is only 15% occurs in the thigh, and all the rest, 85% occurs in the calf. So I don't see the point of obliging somebody to use the long one. I offer, And if they don't want, I don't oblige them. And coming to the point of the compression class, I think there is only one meta-analysis made by Amsler and Blattler concerning the difference between the effectiveness on class 1 and class 2 stockings in people with chronic ulcers. And they were exactly the same effective. So I don't think that there is really a great difference in between class 1 and class 2. It's the same if the patient has strong edema and wants to have something stronger, prescribe 2, and if it's just to prevent, you can use class 1. So in Germany, at least, we are free to choose between both, and everything is reimbursed. We fought a lot for this, and I tend to prescribe only class 2. This means 25 to 32 in Germany at the ankle in patients with thrombosis. And all the others, I prescribe 18 to 25, and I don't see that they are less well treated. But this is feeling, this is not evident.
Okay. Chantal? Okay, I thought she was saying. No, I was asking because it's a personal thing. I had two babies, like one right after the other. I got pregnant. My little one was 9 months old. And I ended up feeling very, very different, like heaviness, even pelvic heaviness, when I changed from the knee highs to the high rise ones. So it was like the feeling was completely different. It's not something that are on the studies, but I could actually feel it, especially for pelvic congestion or something like this. But I just wanted to see if there's anything else related or not. Maybe thank you, everybody.
I agree, and at least that some in my experience with the pregnant woman, they like the panty ones because they want the belly to be whole. There are some devices that hold the belly, and you cannot use many of them, but the panty one, they feel it more comfortable. So probably I agree with your opinion about it. So probably in when the belly is bigger, they feel more comfortable with the high rise. Yeah. Just an opinion. We need to study more about it.
Yeah, I don't see like the thigh highs or the knee highs. I don't see the difference even amongst my patients. But when you change for like something that's only in the leg to something that comes over the belly, when they can put it on, because they have some difficulties to put them on, that's the hard part of it. And I live in a city where it's 40 degrees Celsius throughout the year, so it's not that easy to wear compression either. But it does make a difference, I think. They say so, but something observational, like from my small amount of patients on it. We still have, there's a question on the Q&A that Dr. Erica has already answered from her side. And I wanted to ask to Kathleen the same one. For how long do you recommend keep the pregnant women on stocking after delivery? Dr. Erica answered that for 6 weeks. Yes, the high risk for thrombosis. And I want to hear from you also, Kathleen, your opinion on that.
Yeah, so I think, for sure that 6 weeks in the postpartum period is the highest risk for thrombosis. So I would say that at a minimum. I think it depends a little bit about what you do. When I had my son, I wore compression stockings probably until I finished breastfeeding, just because I felt that there was like a lot of hormonal things going on and my body wasn't back to normal. I think it's a personal decision. We do know that, chronic venous insufficiency that happens in pregnancy is somewhat temporary, but can sort of lead to permanent ramifications. So I think, wearing them, if you like to wear them long-term, will certainly not hurt. There's no downside. And, for people that are in our field, for example, that are on our feet all day, I still wear them when I'm working. So a minimum of 6 weeks and longer if they can tolerate it.
Any other ones? Let's see. Did you encounter any subjects in the study who had difficulties in putting on the compression stockings, and how did you overcome it? Or how do you overcome your patients' difficulties on putting on the stockings when they are pregnant? So I think it might be answered by everybody. Do you want to read your answer? Do you want to read it? Dr. Erica.
Yeah, I said that I especially had problems in taking them off, and when I was in the third trimester, and my husband had to help. But we have you can give them these devices, these donners for compression stocking, and it is really difficult when you have a big baby there to reach your toes. So this is really a question you have to pose the patient. Are you able to put your stockings by yourself? Do you have help? And otherwise, you have to prescribe this helping devices.
There we go. I think we can just move on now. This is always okay. You want below you or above me.
This is one example, by the way, that I have on my desk. It was just like the dolphin donor. I mean, I obviously can't demonstrate it now, but to be honest, this helped me a lot when I couldn't bend down to put them on. I actually tried. You can actually even put on the stocking without using your hands, almost. If you kind of know how to put it on the floor and then kind of slip your foot through, there are a few tips and tricks where this can come in handy.
Yes.
So that's one example of many.
Do you have any other questions from the panel or even from the speakers to each other? Feel free to have a little bit of time ahead of us. So, Stephanie, I pass it on to you.
Yes, so I think now we are slowly coming to the end of the MOH. Oh, I see one more comment coming in. So I can read it real quick from Dilnosa. A very exciting discussion. Thank you for sharing your own experiences from the world. From our experience in Kazakhstan, vascular surgeons prescribe thigh highs and pantyhose to pregnant women in 90% of cases. They would like to have the gradient compression all over their legs. Psychologically, patients like it, right? So it seems like to be a global, agreement. So, right. What I find impressive, I already mentioned this briefly earlier ago, but after having listened to all of these presentations, is really, again, the versatility of side effects that can occur throughout pregnancy. I think most women obviously have heard of morning sickness, nausea, mood swings, food cravings, but I don't know how many pregnant women really understand what happens on a physiological level. I don't know how many really know how many changes occur within the body and how complex it really is. And what I personally find so striking is how something as simple as a sock or a compression stocking can have such a wide range of benefits, from very early on during pregnancy up until after birth. And I truly think we could do a lot to raise the awareness in this area. So Annelies.
I think also, Stephanie, the multidisciplinary approach that we need to follow and work together with the OBGYN and try to do webinars together, because sometimes I can see that they don't really know about these compression devices. They don't work, they don't prescribe it for that reason. So it's really good to work together and open our field.
Yes, this is my point too. We have to focus much more on the gynecologists, because even though my study has been seen and reported lots of times, I don't have the feeling that the gynecologists are aware of the importance of stockings.
So to sum it up, I'd like to say I'm very glad that CVI helped to bring this subject to the spotlight, because venous symptoms are always there for pregnant women. And lots of times they are taken as normal or not important. I mean, it's part of being pregnant, having swollen legs. It's part of being pregnant, having heavy legs. It's part of being pregnant, having varicose veins, and just move on and keep it. And many have no idea of how, like, wearing compression or taking care of it can make such a difference in as many aspects of a pregnant woman life. And some have no idea, and some even doubt, because sometimes when you talk about compression to patients and even to colleagues or OB-GYN colleagues, they say, okay, come on. So you have to be there and trying to convince them. And I think this webinar can finally help us to make a difference, especially for patients, because they are always our main goal. Our main goal is to make the patients feel better. That's why we are all here for. So thanks, Sigvaris, for having us all here. Thanks to our panelists, to our speakers, and of course, special thanks to the audience that are joining us on a Saturday. And I hope to see you very soon somewhere around the globe in person. Thank you.
Thank
Stephanie?
you from our side as well. Thank you from Sigvaris Group to everyone for being here today. I just want to mention very briefly before closing the MOH, you can check out on our website the Stemmer medical platform. If you go onto sigvaris.com, we can send the link afterwards in the chat. You can go to this Stemmer medical platform where we have a lot of materials, literature, including one-pagers that we write on a regular basis, which summarize the most recent literature. And we have two which cover the topic of compression and pregnancy, one of which that summarizes Dr. Mendoza's study, and the other one which is like an overview of compression in general throughout pregnancy. So I think the link just arrived in the chat. So thanks to everyone. Hopefully we can see each other sometime live, perhaps at a congress, at the EVF Congress end of June in Italy, maybe, or at our next global MOH. Thanks a lot, stay healthy, and see you soon. Bye-bye.
Okay, guys. Hello.